It is now my privilege to introduce Maria Stanzik, MS, RDMS, RVT, RT, RM, Assistant Professor and Vascular Sonography Clinical Coordinator, Thomas Jefferson University, Philadelphia, Pennsylvania. Maria.
So good evening, everybody. Thank you, Matt, for that nice introduction. My name is Maria, and I, along with Jessica Stout, are so happy to be spending the evening with you talking about contrast. Before we get down to business, I just have a few housekeeping notes, starting with expressing gratitude from the co-presidents of ICUS, Dr. Feinstein and Dr. Wilson. They would like to extend a warm welcome to all participants in today's webinar. They would also like to acknowledge and thank Intellios and ARDMS for partnering with ICUS on today's program. Intellios represents more than 150,000 healthcare professionals and defines excellence through quality patient care and certification. And the ARDMS, which is affiliated with Intellios, administers examinations and awards credentials. So by fostering this collaboration with Intellios, ICUS can enhance the capabilities and acceptance of CEUS in clinical practice, ultimately leading to better patient outcomes. Furthermore, Dr. Feinstein and Dr. Wilson would like to thank our friends at Northwest Imaging Forums, the exclusive CME provider for ICUS. So what is ICUS? ICUS is the only global professional society solely focused on CEUS. Members are in 75 countries. They are comprised of a variety of healthcare professionals in a variety of specialty areas. ICUS is deeply committed to CEUS. In fact, their mission includes to promote the safe use of contrast enhanced ultrasound in patients with diverse medical profiles and disease states. Furthermore, ICUS is dedicated to CEUS education. They set out to provide a global interdisciplinary forum to foster education, research, and development of CEUS applications. What makes ICUS so unique is everything is free. So feel free to scan the QR code and become a member of ICUS because membership to ICUS is free. The website is accessible for free. All webinars and CME is available to you for free. There is a free mobile app referred to as ICUS Connect, which is compatible with your Apple and Android devices. And there is also a free CEUS news monitor. And the News Monitor will provide you trends and developments both nationally and internationally pertaining to contrast. So it's basically the latest, greatest information, all the bubble news and announcements with links to the latest publications and more. And the CEUS News Monitor is available to you in English and in Mandarin, and other translations are also available to you. So we encourage you all to explore the ICUS website. It is the most comprehensive suite of CEUS resources. There you will find information on upcoming webinars, including registration links. There is sponsor virtual exhibits, product information, and links to sponsoring websites. And we encourage you to scan the QR codes and download the ICUS Connect app. It is a free mobile app. It is all things CEUS right there at your fingertips 24/7. So why not earn free CMEs while watching an ICUS webinar on your smartphone? So the Sonographer Training Resource Hub, that is accessible on the ICUS website. It is divided into two, CEUS in Echo and CEUS in General Sonography. There you will find scalable plug-and-play modules for sonography training curricula, links to product labels, webinars, reference materials, and more. Perhaps you're in need of IV training. So ICUS has collaborated with Northwest Imaging Forums on the development of an IV training program, and it's divided into two steps. The first step is an online didactic component in which you can earn CMEs, and the second step is a hands-on IV insertion component in which you can also earn additional CMEs. So tell your colleagues to join ICUS. Again, feel free to scan the QR code, and we invite you to join the CEUS conversation by liking us, following us on LinkedIn, Instagram, Facebook, and more. So lastly, ICUS would like to express sincere appreciation to the 2025 sponsors that are listed here. Not only do they provide generous support to the organization, but they also provide leadership within our profession. So without further ado, now let's get down to business, fun stuff of talking about bubbles. So this is today's agenda. I do want to notify you that I added just a little bit about a description of UCAs and case review. These are my disclosures, and I think a great place to start is by describing exactly what ultrasound contrast agents are. Essentially, they are a bubble referred to as a microbubble. That bubble is comprised of a low soluble gas core. That gas core is an important component because that's what determines the bubble's echogenicity. That gas core is encapsulated by an outer shell. That outer shell is an important component because that's what determines the bubble's stability. So when you put these two components together, what you have is a bright bubble that we can easily see, and it is stable, which means we can image it for a period of time. How do we image using contrast agents? Essentially, they respond to ultrasound stimulation. So the minute that bubble enters an ultrasound environment or interacts with an ultrasound wave, it reacts. So it begins to expand and contract in response to that ultrasound stimulation. And that is the video that we are seeing here. As that bubble is expanding and contracting, it is releasing backscattered signals to our system. We control the amount of backscattered signals that are produced by the acoustic power on our system. So the agents that we use dissolve in circulation. They do not pass through Bowman's capsule, and that's what sets them apart from contrast that is used in CT and MRI examinations. So the agents that we use are purely intravascular agents, and they are not nephrotoxic. So they are safe to use on patients that have compromised kidney disease, where CT and MRI contrast may be contraindicated. And I want you to think of the agents as sort of flowing passively through the blood vessels along with the other blood products. And in fact, that's the image that we are seeing here. This image was acquired with a high-speed microflow camera. It is a blood vessel that contains contrast agents. And I think you can appreciate how the microbubbles sort of flow through the vasculature, providing us an accurate depiction of vascular architecture at improved temporal and spatial resolution. So these agents are able to pass through the smallest of capillaries. And let's face it, what makes ultrasound so special is the fact that we are watching real-time perfusion. Ultrasound allows us to perform dynamic imaging. So these cine clips were provided to me by Dr. Wilson from her lead CEUS sonographer, Christina Merrill, out of the University of Calgary. And I love these cine clips because they really illustrate the power of UCAs. So what makes ultrasound contrast agents different than our traditional color Doppler imaging tools? Well, on the left, of course, we see the main portal vein. We see this big vessel, fast-moving flow. On the right, on the contrast side, not only are we seeing those same large vessels, but we are also seeing flow at the capillary level. So CEUS provides excellent resolution at high frame rates, superior to those that are acquired with contrast enhanced CT and MRI. And quite frankly, let's face it, our patients prefer it. So these are the agents that are approved. We have Lumason. Lumason has a global name of SonoView. Lumason is approved for the characterization of liver lesions in adult and pediatric patients. Lumason has approval for the diagnosis and treatment response of urinary reflux in pediatric patients. Lumason also has approval for cardiac applications. Definity has approval for cardiac applications in adult and pediatric patients, and Optison has approval for cardiac applications. Contraindications. To date, the only contraindications that exist are if the patient is hypersensitive to the bubbles components. A full list of the bubbles components can be found within the packaging insert that comes within the contrast kit, can be found on the manufacturer website, can also be found on the FDA website. So I want to share with you just a few cases in which ultrasound contrast agents are used to interpret and improve patient outcomes, starting with urinary reflux cases in pediatric patients. And these images were provided to me courtesy of Dr. Casadarj out of the Children's Hospital of Philadelphia. So how can we use contrast agents to diagnose urinary reflux? I want you to think of the agents. When you're working with them, just consider yourself like a bubble chaser. So wherever the bubbles go, we will follow. So you can see the image on the top left. That is grade 1 urinary reflux. What we see, which is highlighted in that yellow circle, is bubble activity. We see enhancement in that distal ureter. Of course, grade 3, which is the image on the far right top, we see microbubbles in the pelvic calyces. We have significant pelvic dilatation. And then grade 5, we have microbubbles filling the pelvic calyces, significant dilation, and then a dilated tortuous ureter as well. In fact, research has shown that 65% of grade 1 urinary reflux cases that were diagnosed using traditional VCUG were actually turned out to be grade 2 when you incorporated CEUS. And with CEUS, if it's coupled with some additional tools like 3D, 4D, not only does it do a better job at grading urinary reflux, but it also does a better job at identifying ectopic insertion of the ureters. So liver CEUS is used to characterize liver lesions in adult and pediatric patients. And because the liver has a unique dual blood supply in hepatic artery and portal vein, there are distinct phases that we see throughout the cardiac cycle. And I'm just going to quickly review those phases with you. The first phase is the arterial phase that typically occurs about 10 to 20 seconds after injection. What we start to see is enhancement of the hepatic artery. The second phase is the portal phase. We see more bubble activity in the liver parenchyma. We see enhancement of the portal vein. What we do not see is enhancement of the hepatic vein. The blood in the contrast has not arrived in the hepatic vein just yet. And in the late phase, sometimes referred to as the late portal phase, we see more uniform enhancement throughout the liver. We now have enhancement in the portal vein as well as hepatic vein. So the World Federation and European Federation of Ultrasound in Medicine and Biology have created a set of guidelines for the use of contrast enhanced ultrasound to characterize liver lesions. And it's oftentimes how these lesions present in each of these phases that help determine, is this a benign process or is this a malignant process? It's very characteristic for benign processes to retain the contrast in those late phases, the longer we image, just like it's very customary for malignant processes to wash the contrast out either in that portal phase or in that late phase. Now let's take a look at a case. I love sharing this case. So this was a 65-year-old gentleman who presented with a right lobe liver lesion, and I think you can appreciate that on the grayscale sonogram in the middle there. This patient had a history of cirrhosis and portal hypertension, and you can see ascites. In addition to that, the patient had severe compromised kidney disease and kidney function. So CT and MRI contrast was contraindicated. So this patient, this lesion was under surveillance. He was having a series of not only ultrasounds, but also unenhanced CT. This lesion was stable for a little over a year. After having several imaging tests, his clinician suggested that they that they get the lesion characterized. So he ordered a biopsy. We do our contrast study. The lesion hyperenhances in the arterial phase and washes the contrast out in the late phase. So based on that, this was diagnosed as being an HCC. Why I love to show this case is because it truly is a win for ultrasound. This is the best part. The patient's clinician didn't believe the diagnosis. He said this lesion was stable for way too long for this to be anything other than a benign process. So the patient's clinician ordered a biopsy. Biopsy confirmed the diagnosis of HCC. The patient went on to have the lesion radioablated. We repeated our study to check post-treatment response. Now what we see is an ablation cavity completely devoid of enhancement, indicative of a successful treatment response. So as I like to say, it was a real win for ultrasound. So EVAR, endovascular aortic repair, is commonly being performed to treat abdominal aortic aneurysms. And it's very customary for those patients to be followed after their EVAR procedure, either with CT or ultrasound, but sometimes the ultrasound is a little bit difficult to perform. So what you are seeing here is a schematic diagram of the various types of endoleaks. And I want you to remember, when you're working with contrast, you're a bubble chaser. So everywhere you see little droplets of blood on this schematic diagram is where you would expect to see the presence of microbubbles. So let's take a look. I do want to mention that these images are courtesy of Dr. Andrei Lyshak and his CEUS lab from Thomas Jefferson University. So let's have a look. So no doubt this patient has an endoleak. One of the ways that endoleaks get characterized is by determining whether or not you are seeing antegrade or retrograde flow. But as you can see with traditional color Doppler, we are seeing to and fro flow detected at the distal graft attachment site. So we're unable to really effectively characterize this type of endoleak. So let's take a look at the contrast study. So what you are about to witness is synchronous enhancement of the aneurysmal sac and endograft suggestive of an antegrade leak. So because of that antegrade leak, this was diagnosed as being a type 1B endoleak. So remember, working with contrast agents are much more sensitive to detecting flow better than our traditional color Doppler tools. Case in point, the still images that you see here on the left, the top image, you can appreciate that no flow was detected posterior to that graft. However, when contrast was incorporated, this patient was actually diagnosed as having a type 2 endoleak based on collateral flow that was identified in the IMA, as well as the posterior lumbar artery, which is indicated there by the arrow. Furthermore, contrast provides the validation and reassurance of a negative exam, as displayed in the image on the right here. So here we have an aorta that enhances and an aneurysmal sac that remains devoid of enhancement, consistent with no evidence of an endoleak. So can we use UCAs to characterize kidney lesions? Well, in fact, yes. So the phases for renal CEUS are a little bit different than that of the liver because with the kidney, there's really just one blood supply in the renal artery. So the first phase is the arterial phase. What you will begin to see is bubble enhancement in the renal arteries. The second phase is the cortical phase. What you see is enhancement in the renal cortex. However, we do not see enhancement in the medullary pyramids. And then the last phase is the medullary phase. We see more uniform enhancement, homogeneous enhancement throughout the kidney. We see enhancement in the medullary pyramids as well as in the cortex. Let's take a look at a case. So this was an 84-year-old gentleman. He presented with bilateral hemorrhagic cysts, as well as what was suspected to be bilateral upper pole kidney masses. And you can see in the image on the bottom left there, that right kidney upper pole, we do detect a little peripheral flow within that suspected mass, but the left kidney, we did not detect flow using color Doppler. So let's take a look at that left kidney upper pole lesion. So no doubt, bubbles are arriving. That lesion is enhancing. This was diagnosed as being renal cell carcinoma. And in fact, we did a second injection to evaluate that right kidney upper pole mass. And in fact, the patient was diagnosed with bilateral renal cell carcinomas. Just to show you the difference in RCC, and we were actually able to interrogate a nearby hemorrhagic cyst. The top row that you see here is that left kidney renal cell carcinoma where we saw hyperenhancement in the arterial phase and cortical phase. And actually, we're beginning to see a little bit of washout of the contrast in that cortical phase, as well as you can see the contrast completely washed out in the medullary phase. Whereas in comparison, that nearby hemorrhagic cyst remains anechoic throughout each of those phases. So can we use ultrasound contrast agents to assess post-treatment response? This is another case that I love to share. This was a 61-year-old female patient who had a known angiomyolipoma, and you can see it's quite large looking at that CT. The patient had the angiomyolipoma embolized. However, she continued to complain of left upper quadrant pain. So she went back to her clinician. She got a series of CTs, which determined maybe slight decrease in tumor size. She was getting ultrasounds. However, due to the size, it was a little bit hard technically to really say whether or not the tumor changed in size. At one point, the patient had an arteriogram, which determined that no residual arterial supply was discovered or diagnosed. So the patient went back and forth with these series of imaging tools. This went on for 14 months. Keep in mind, the patient kept complaining of left upper quadrant pain in this time. Finally, her clinician ordered a CEUS examination, and that's what you see on the far right there. No doubt, there is still active, viable tissue in this AML. And in fact, that small anechoic area that you see within the AML represents the only portion of that, that tumor that was actually successfully embolized. So I can tell you that the patient actually went on to have her angiomyolipoma re-embolized. We've repeated our contrast study, and it was successful the second time around. So I'm sharing with you those cases in part because I just think it's important to have an understanding of the power of the medium and just how directly it benefits patient care and improving patient outcomes. Furthermore, I also intentionally shared with you the CEUS labs that provided me those cine clips and still images, because I want you to know that contrast is being performed routinely, and it must be performed routinely. So now I want to take a few moments to talk about the SDMS scope of practice and clinical standards for the diagnostic medical sonographer. So this really defines our role as healthcare professionals working within an interdisciplinary healthcare team. So basically it's what can we do, what's ethical, what's legal, those types of things. So the SDMS scope of practice was revised last year, and ICUS was part of that task force. So the key elements that were included and clarified on the revised SDMS scope of practice involve the sonographer's ability to place an IV, to administer a contrast agent, and to determine when contrast is necessary. And that last bullet point, when you think about it, this is how we function on a daily basis. How many of us, perhaps we're scanning a gallbladder, we see something suspicious in the kidney, we notify the radiologist, we call and get a script, and we add a kidney examination to our study. That is how we function on a daily basis. That's just good patient care. So I want to take a few moments to talk about how we place an IV, starting with the equipment that is necessary. And I know Jess, I believe, is going to talk about the same thing, intravenous, but from a cardiac perspective. So what you are seeing here is for the general sonographer. So we typically implement a three-way stopcock. We use a 5 to 10 ml saline flush, and we use an 18 to 22 gauge angiocatheter. Usually we inject through a 20 gauge angiocatheter. Now you may think we're never going to put a 20 gauge needle into a pediatric patient. You can use a smaller needle diameter such as a 23 or 24, but you will just need to inject at a slower rate. The reason why we use a little bit of a larger needle diameter is because we are working with a bubble, so you want to preserve the integrity of that bubble. I'm going to pause this just for a moment. To the left here, we have the two different types of systems. We have a closed IV system as well as an open. And then, as I mentioned, this is for the general sonographer. We typically implement a three-way stopcock. What you are about to see is initially we start by injecting 2 cc's of that saline flush to prime the line, make sure the line is stable, followed by injecting the contents of the contrast syringe, and we inject over 3 to 5 seconds, followed by injecting the remaining saline flush. And the purpose of that secondary saline flush is to help push the bubbles along. The other thing I want to mention about this setup is the fact that our saline flush is always set up at 90 degrees, and you always want that contrast syringe to be set up to flow in a straight direction. So let's take a look. And there is that secondary saline flush. So some additional notes about IV placement regarding outpatients. You want to try to use that left arm because ordinarily we do work from the right side, so it just makes the IV more accessible. Antecubital veins are preferred. We tend to like those larger veins because, again, we're preserving the integrity of that bubble. Regarding inpatients, you can use existing IVs. However, you need to check with the nurse to make sure no filter is placed anywhere along that route of transmission. If there is a filter in place, it will filter out the bubbles. You have to check with the nurse to make sure that they shut off the meds. If the meds are not able to be shut off, then yes, you will need to gain a different access route. Regarding central or port line injections, so sonographers do not inject through central or port lines. That practice is reserved for physician or nurses. However, I always encourage people just check with your institution's policy about using a central or port line for a radiologic contrast examination. So you want to make sure you're adhering to your institution's policy. I'm going to take a quick moment to talk about a protocol, and this protocol is based on the ACR LIRADS recommendation. So this is a liver study that you were about to see. Remember, the true benefit of ultrasound is the fact that we are performing dynamic imaging, live imaging. So we want to see that perfusion as it's happening. So our initial cine clip, and when we perform contrast studies, we are acquiring cine clips. That initial clip is a 60 to 70 second cine clip, and you can see the bubbles arriving here. After which we stop scanning. And then we will acquire another 5-second clip 2 minutes after injection, stop scanning. We acquire another 5-second clip 3 minutes after injection, stop scanning. We continue to acquire 5-second clips every minute after injection until the question is answered or the contrast is dissipated. We do not do continual scanning because you want to preserve, again, the integrity of that bubble. Now, if you have difficulty maintaining your position, you can do 2 injections, one to assess the arterial phase and then one to assess the later phases. Now, what recordings are necessary? So what you are about to see, this was an HCC that was chemoembolized, and we were using contrast to assess a treatment response. So you can see bubbles in the heart, bubbles arriving in the liver. Here is the lesion here. No doubt this lesion still has lots of viable tissue, and you're going to see me sweep through this lesion, and that anechoic area that you see represents the only portion of that lesion that was successfully chemoembolized. So what recordings are necessary? We must document peak arterial enhancement. We document those intermittent recordings, and then we document washout. And as we are observing this, we're already starting to see some washout. In regards to what the radiologist needs to report, it's basically the same thing as you would report for a contrast enhanced CT or MRI. So that is date and time of study, contrast agent, dosage, lot number, number of injections, including saline flush, method of transmission, and adverse events. And just a note about the safety profile of these agents. So Jess will talk about the need for having a contrast reaction kit, but that's what's imaged here. So just like CT and MRI has a contrast reaction kit readily available, so do we when we perform our studies. But regarding the safety profile of these agents, so there was a huge retrospective large-scale study that looked into the safety of sulfur hexafluoride. And sulfur hexafluoride is the gas component of the agent that is used and approved for general imaging. So this study concluded that no fatal events were observed good safety profile. Regarding adverse event rates, they were less than that of agents that are commonly used in radiology, radiologic and MRI studies. So for a full list of comparison between UCAs and other contrast agents, we would encourage you to visit the ICUS website and look for safety comparison of adverse events. And this is hot off the press. And this was truly spearheaded by Dr. Strom, who serves on the ICUS board. And Dr. Strom really felt like was super important to provide institution safety guidelines so that they allow sonographers to administer UCAs at the point of care. So he drafted this, sent this out to multiple professional organizations, and developed what is entitled Multi-Societal Expert Consensus Statement on the Safe Administration of Ultrasound Contrast Agents. And this was published the last week of February in Echo Research and Practice. So this expert consensus statement serves to outline what constitutes appropriate supervision and the essential components of safe CEUS practice. So this is consistent with the updated, newly revised STMS scope of practice, and it also mirrors the practice parameters set forth by the ACR for contrast enhanced CT and MRI. So I'm going to ask you this question: why CEUS? So just like MFM, just like MSK, just like vascular are specialty fields within our profession, so is CEUS. So the windowing and image production for CEUS is a unique and challenging skill set, but sonographers are lifelong learners. Learning, developing our skills, that's what we do best. And in fact, contrast has been used worldwide since about 2000. The first FDA-approved ultrasound contrast agent for general imaging occurred in 2016, and Canada approved UCAs back in 2002. So why CEUS? Because it invites the best of the best. Now, is it appropriate to use? Well, according to the ACR, it is. So the ACR has appropriateness criteria, and this criteria is evidence-based guidelines to assist referring physicians and other providers in making the most appropriate imaging or treatment decision for a specific clinical condition. You will see CEUS listed in the clinical setting of initial characterization of liver lesions in patients, as well as in the clinical setting of indeterminate renal mass. So this too is hot off the press, and this is really a call to action. So the Organ Procurement and Transplantation Network, referred to as OPTN, they proposed a policy update that will recognize contrast-enhanced ultrasound as an acceptable diagnostic imaging tool for evaluating HCC. And this will align with imaging classification criteria to the LIRADS. And to the left, you see the diagram of the LIRADS. The CEUS LIRADS are a standardized system for technique, interpretation, reporting, and data collection for contrast-enhanced ultrasound examinations in patients at risk for developing HCC. So this call to action is really about posting public comments in favor or in support of this proposed policy update. So we encourage all of you to visit the OPTN website and provide feedback. Maybe you have a personal experience, maybe you're a sonographer, physician, and we would love to hear you not only in support of this policy update, but express the benefit of CEUS. So we're back to this question: why CEUS? So as patients, and let's face it, we will all be patients at one point or another, contrast enhanced ultrasound is a tool that does not use radiation, is non-invasive, safe, well tolerated, has proven to reduce downstream testing, thus leading to faster diagnoses. As educators, and I am a full-time educator, I firmly believe we have the responsibility to prepare our students ready to deliver innovative care to the communities they serve. And I think as sonographers, I feel like we all have a dual role. Some of us are clinical educators, some of us are adjunct, but oftentimes we have one foot in many different environments. So it's important that we recognize that we have to prepare our students. So I'm going to take a few moments to talk about the importance of integrating contrast enhanced ultrasound into sonography programs, starting with Sonography Canada. So Sonography Canada National Competency Profiles say that it is mandatory that cardiac and vascular sonography programs IV train their students. Furthermore, they also say that CEUS curriculum must be taught in all concentrations. So go Canada, because you are forward thinking. In the United States, our model of education in sonography is a little bit different. We have CAHAP. CAHAP is the overarching accrediting body. The JRC DMS provides recommendations about accreditation to CAHAP. So the JRC DMS is a member of CAHAP. And really, the mission of the JRC DMS is to establish and maintain and promote quality standards for sonography education. Why am I talking about JRC DMS? Well, they house the National Education Curriculum. And in fact, the National Education Curriculum was under review between 2022 and 2023. That newly revised National Education Curriculum is set for a board vote in spring of 2025, followed by it will be sent to sponsoring organizations and released to the public. And that will happen spring to summer 2025. If adopted, the newly revised NEC will expand CEUS education in sonography training programs. Now, you may think to yourself, you don't have, as an educator, you may not have access to contrast software or contrast agent. How are you going to engage your learners and teach and incorporate contrast curriculum into your programs? So what you are seeing here is a homemade phantom. I made this with Metamucil and gelatin. I sipped it through a piece of vinyl tubing. This is actually agitated saline. We can teach our students some critical concepts about contrast enhanced ultrasound, starting with what happens if we image contrast using a high mechanical index compared to a low mechanical index. I have to tell you, this was taken with a traditional ultrasound machine. The only thing I did was adjust the output power. We can also teach our students how to properly inject. And I took my traditional system and I went into dual image mode. I allocated one side to be the contrast side. I reduced my overall gain. We injected contrast. And now I can show my students exactly what they can expect after injection. So I will tell you that dual imaging mode, reduce your power, and it really does a very nice job at simulating a pre and post injection display. We can also teach our students how to properly inject. What happens when you inject too fast compared to what happens when you inject over 3 to 5 seconds. So this just shows you some concepts that I developed to show our students and to actively engage them so they are excited about performing contrast and they have incorporated that into their knowledge base. Furthermore, I do think it's important that we teach our students the importance of becoming IV trained and really reducing fear about working with needles. So what you are seeing here, and I incorporated this into an interventional procedures lecture, it's a piece of tofu. I sifted a straw in there and then put a needle in so that I can help my students identify the needle. And again, it's about making them confident, reducing fear about working with needles. So we are back to this question, why CEUS? So I was recently asked just less than a week ago about from a hospital administrator, and he challenged me and said, why would he bother adding contrast enhanced ultrasound to his department? So I said to him, it enhances visibility in your department by expanding the application. So you are providing this innovative technology and care to your patients. Your patients will remember. Think about the cost effectiveness. So CEUS requires less infrastructure and it improves workflow. promotes patient retention. Consider if you have a backlog of CT and MRI, could you use contrast enhanced ultrasound to answer some of those critical clinical questions, therefore opening table time? And I will tell you, your staff will appreciate you. As a sonographer, I love when my administrators invest in me. So it definitely, I would say, improves motivation within your department. What you are seeing here is the projected growth of CEUS. So the global contrast enhanced ultrasound market was estimated in 2023 at $2 billion. And there is an expected compound annual growth rate of almost 6% between the years 2024 and 2030. And that growth can be attributed to many factors, such as the availability of an affordable contrast agent, increase in the number of ultrasound procedures being performed, and integration of contrast imaging modes into ultrasound systems. But we have some work to do, and that starts with advocacy and awareness. So wherever you are professionally, whether you're a new sonographer, seasoned sonographer, I want you to consider the many advancements in technology in the time that you have been practicing. Now, imagine what the future holds. So how do you think our profession will change and improve over the next 5 or 10 years? So I am really excited about what the future holds for our profession, but we have some work to do. And that starts with promoting CEUS. So advocate within your departments, highlight the benefits and the use of UCAs in specific clinical scenarios. Provide educational materials not only to the radiologists, but referring physicians. How about the hepatologist? How about the urologist? Enlighten them about the power of this tool. And then lastly, as a sonographer, commit yourself to advancing your skill set and knowledge. Commit yourself to becoming IV certified and seek out opportunities to learn more about CEUS. So with that, I would like to introduce my co-presenter and esteemed colleague, Jess Stout, who is the Director for Non-Invasive Cardiology at Beth Israel in Boston. So I am going to stop sharing my screen and pass it over to Jess.
Thanks, Maria. That was amazing, as always. I always forget about the tofu, and then I remember the tofu. Whenever you say it, I always think it's so cool. So you're an amazing educator, and I appreciate all of these webinars and doing them with you. So thank you. So I'm going to shift gears a little bit here. I'm going to just take 1 second to share my screen. Bear with me for 1 second. So we're going to shift gears a little bit and talk about cardiac now, and also just expand a little bit on what Maria said about encouraging the use of contrast enhanced ultrasound and how to implement in our departments and work with administration to make sure that we're advocating for our sonographers, for our staff, and for our patients ultimately. So my disclosures here. So I'm going to start and just throw Beth Israel right under the bus here, and talk about how far we've had to come in our ultrasound contrast ultrasound use. And so this is from the last 18 years, going up to 2018, and the UEAs were significantly underutilized here. We looked at 171,000 TTEs, and over the 18 years, and only 2.6% of our patients received UEAs. And even despite that, almost 17% of our TTEs were suboptimal. So at the very least, you would think that the amount of UEA we are giving would be somewhat consistent with the amount of studies that were suboptimal. And that just wasn't the case. And 2.6% is incredibly low. Granted, we weren't using a lot of contrast back in 2000, but this was pretty low, and it wasn't increasing at the same proportion as our suboptimal studies were. And so we had a little bit of an issue with the use of contrast agent here. And a lot of that was because of workflow. And I do have to say, Jordy Strom, Dr. Strom, who Maria mentioned, he's our medical director here. And we did have to change this chart and update it to show this through 2022, because we do talks throughout the nationally about contrast. And I said, Jordy, if we keep showing it only to 2018, we're gonna really look like we don't know what we're talking about. So you can see that we have increased the use here at BI, and really have Jordy's been a pretty big part in helping to do that. So one of the main things that we see that I think everybody sees, and this is based on a 2021 ASC Trends report, what is the hardest part? What is your most difficult tasks day to day? And that's patients with difficult body habitus, right? And we know that that UEAs can fix that and help that, and yet we're not using them enough. And it's because there's still a lot of these workflow barriers that we see. 27% of people said it's just too much effort. Sonographers aren't trained. They're just not in favor of using it because of workflow efficiency issues. And I completely get it. And these are significant concerns that, on the surface look like they are, really hard to overcome. But I think we have all these organizations now coming together, ICUS and ARDMS, and to really try to give people the tools to do this, with administration and with their sonographers, to help overcome some of these barriers here. And just like Maria said, the why, I'm all about the why, why bother? And every time I do a contrast talk, I always show this slide. And this is from a study done out of Houston Methodist that looked at, what happens to these patients when we give them our contrast agents. On the left, you have patients that are technically difficult. You have uninterpretable, technically difficult studies in the red and the yellow. And then after you give them a contrast on the right, you see that the uninterpretable studies dropped from 11.7% to 0.3%, and our technically difficult studies dropped from 86.7% to 9.8%. I mean, that's huge. We're getting a better answer. We're giving a better test to our patient. That in itself is enough reason to use contrast. But the study went one step farther and said, okay, well, we have better pictures. We're able to get a better test. What else did this do? And they actually did show that using the contrast agent did result in avoidance of further testing downstream. So 55% of patients in surgical ICU avoided another test, a nuclear imaging, a TEE, and also, up to 63% of patients in the surgical ICU had a change in management, whether it was a procedure avoided and a medication change or just a medication change. I mean, so that's huge. We're getting a better answer more efficiently. It's better for the patient. We're saving money, all of these things. And so this study really shows, how important contrast is in our day-to-day. So, as I said, our contrast use here was lacking, and you can see it over the years, we have increased it, but we had these same workflow barriers that everybody else is having right now. We had, sonographers that were really concerned about quantity. They wanted to make sure they got their, 7 studies done a day. And for me as a director, I'd rather, less studies if they're really high quality than trying to rush through more studies. And, if you think about it, our attendings now are used to reading higher quality studies with contrast. And so if they're reading these rush studies, what are they going to say? Go back tomorrow and do another one with contrast, right? And so it's actually not helping because we just have to repeat the study with contrast anyway. So, really trying to work with the sonographers to understand the why and why it's important to use, do QA and QI with them, and really work directly with them to do case reviews and things like that. Workflow as far as injecting was huge. BI in itself is very geographically dispersed here in Boston. So we have 5 labs on our main campus. And we had one poor fellow that had to schlep around between all 5 labs to give the contrast. And nobody's going to wait for that, right? Sonographers don't have time to wait for a fellow to show up and inject it when they have to come, across the street and down the road or wherever they were. So transitioning to sonographers injecting really helped our workflow and made it so that we were using a more appropriate amount. And finally, physician, we have our physician champion, Jordy, who loves bubbles. And I say between the two of us, we're probably completely insufferable because we both love contrast so much. But we're a great team and we both believe in the same thing for the lab here. So sonographers injecting, to get this through administration, all we really had to do was do what everyone else was doing in the hospital. And that's, you know, I want to say, when you're looking at your hospital and how to incorporate some of these things, look at what other areas are doing. Let's not reinvent the wheel here, right? So radiology was already doing this, MRI, nuke med, ophthalmology, they were already administering meds. And so there was already a policy in place. We just had to go to the Med Exec Committee and the Pharmacy and Therapeutics Committee and advocate for our sonographers to be included on that. And you can see here, it says, you know, if you don't have a state licensing board, if you're an employee and you have a scope of practice that includes the administration of a specific type of medication, then you are cleared to do that. And so once we got it approved, we do have cardiac sonographers added to this list of recognized professionals that can administer the contrast agents here at the hospital. So when we're doing, when we're supporting our sonographers to do injections and to do these things, we want to make sure that we are truly supporting them, and that's so important because we need to make sure that they're comfortable. And, you know, so that starts with initial and annual competency assessments. And so your initial assessments need to include, you know, something as easy to us that have been doing it for, you know, 15 years is how to mix it correctly, right? How to just assess a basic IV, not put it in, but just assess one, how to clean it, how to flush it, different kinds of IV access, what to use, the appropriate indications for use of contrast, the recognition of adverse reactions, a policy for addressing those. And, you know, I can't stress this enough, use your clinical application specialist to help your new sonographers with scanning techniques and machine optimization. That's what they're there for. I have a brand new sonographer that just graduated, and I have one of our clinical application specialists coming on site tomorrow just to work specifically with her and just help her in her day-to-day use. So use the tools that you have available to you. So appropriate indications here for us, this is our policy, and this is not, of course, the only reason that we're using contrast, but the expectation is if a patient presents with one of these things, contrast will be used 100% of the time. And so things like suboptimal echoes, we know that's a big one, but known or suspected apical HCM, apical akinesis or aneurysm, the vascularity of intracardiac masses and things like that. So having it down and clearly defining expectations is really important. And this chart I love. You know, I think for so many of us that have been doing echo, it was drilled into our brains so long that we only use contrast, or you should use contrast when you don't see two or more continuous segments on echo. And while that's true, it's not the only reason we should be using contrast. And I think that's it's really grown so far beyond that. And this is a great chart that shows, you know, we know that in a poor quality echo, for a variety of clinical indication, there is a high benefit of use for contrast. But even in specific indications with a good quality echo, there is still a really high benefit of use. So think about your patients that are going through cardiotoxic chemotherapy, your patients that are getting looked at for valve intervention. You need a specific EF, ICD, your stress echo, your thrombus, your chest pain. All of these things, even if you have a good quality echo, contrast can still be instrumental to get the answer. And I could do an entire presentation showing good quality echoes that had contrast that showed something completely different than we would have thought and really changed management. So it is so important to go beyond that thinking. It's like an antiquated way of thinking now that we're only using it for suboptimal echoes. It's just not the case anymore. So, you know, in order to support our sonographers in injecting, you know, we also want to make sure that we are supporting them should an adverse event happen. And this is not to scare anybody. This is not to, you know, make anybody nervous. But the reality is it doesn't happen very often. But there is potential for an adverse reaction. And so if sonographers are injecting, they need to know how to handle that appropriately. And so the first thing is, sonographers need to know what to look for, what is an adverse reaction. And with all of our contrast agents, the most common adverse reactions are things like nausea and headaches and things that honestly I don't think I've ever seen. And those are really usually self-resolving. It's these anaphylactoid type reactions that we really need to look for and be cautious of, because those are the ones that can warrant additional treatment. And so things that we're looking for is the periorbital swelling that we're seeing here, hives, redness, things like that. So you need to create an institutional policy that works for you. For us, we call the fellow immediately comes, and if we need more support, we are calling the rapid response team, or hopefully not the code team. That works for us because we have a ton of fellows, and you might be an institution where you need nursing support, and that would look better for you. Either way, it's just important that everybody knows their role and what the expectation is should something happen. And I can't stress this enough. Debriefing with staff after is so important, because that's where we learn, and that's where we learn what we could have done better, or what we could have changed, or what we can do differently. And we've made a lot of changes in our lab based on our response to reactions. And one of them is this little chart that I have on the right here. And I know it says, it's very, it looks very simple, but it's really just, it's just a kind of a go-to guide, so that when you're in the moment, you don't have to think about it. You can just look at the chart, know who to call, and just be done with it. There's a reason that we have on our badges phone numbers and things like that for who to call and what the codes are. And that's because when something happens in the moment, we kind of go blank. And so the sonographers have all the contact info. Should something happen, it's posted on all the outpatient rooms. And this was at their request, and I think it's something really simple that provides a little bit of additional reassurance to them. Again, having an allergy kit nearby. All of our labs have an allergy kit, and ours is a little overkill. I don't think you need this whole the whole thing, but have an EpiPen nearby at the very least. That's going to be the best thing for a significant kind of anaphylactic reaction. There's a wide variety of things in this, and we're able to, we lock it. We have the number lock on it, similar to code carts. We record that the lock's not broken and check expirations once a month on it. Joint Commission checked off on it. They said that was fine. So we have it stored just in case, but if nothing else, just have an EpiPen nearby. So, Maria touched on this, and she's done incredible work on working on this and working with the JRD and CMS on this. But, we're really looking at these barriers to IV starting so early and starting in our schools, and how can we improve that and get students coming out of school already trained and going forward, because it's really hard once you're kind of in the mix and you're not trained and you're not exposed to contrast, and why it's important to then show up to work and have to kind of rethink and get additional training. And so if we can really push this curriculum and have it as a requirement, I think that will really show, just prove to be so beneficial. But for now, what we can do is offer IV certification and training to our staff. And there's different ways to do this. I'll say that there's some staff that just don't want to do it, or they're just they're a little nervous, and I completely understand. Try to incentivize them. How do we incentivize staff? We give them more money, right? And so I know that's not always feasible, but we did transition to a tiered sonographer approach not too long ago. And so we have sonographer 1, 2, 3, and like lead sonographers and a technical director now. And the way you go up in the tiers has actually nothing to do with your years of experience, because I don't actually think that amounts to what level you should be at. I think the level you're at should equate to what you're doing day to day. Are you doing additional things? Are you doing IVs? Are you doing stress echoes? Are you doing cath lab procedures? So all of those things are integrated into our tiers. And once you do get so many things, you can go up to the next tier. So Incentivation, money always works if nothing else. But when trying to incorporate training, again, model it after departments where we already have non-nursing staff doing this. MRI, nuke med, stress departments. Go to your cath lab nurses, your IV therapy teams, and talk about what they're doing and try to get their support in training your team. My IV therapy team, one of the managers called me the other day. She said, or not too long ago, she said, Jess, you're killing me like with all these requests. I said, so come and train my sonographers and then, we're good. And so we talked a little bit about that and she's considering some additional training, but definitely work with what's already established and to try to get some training done. So this is what we do in our department for competencies. We just do like an online course through the hospital. It's not like a course, it's like a movie that looks like it's from 1987 about doing an IV. And then we have a in-person didactic session with one of the advanced sonographers. We practice on the fake arm. They observe an IV placement, and then we do 5 on IVs, or 5 real IVs on patients. But I can't stress it enough. It's the consistent repetition that really matters. And then this is just our competency that we fill out for every sonographer. So we do this for 5 patients, and it just goes through and you mark it off that it's been complete. So again, repetition, repetition, repetition. We're not going to get all those beautiful IVs. Sometimes you're going to get those really tough sticks. So it's really important to just, once you have that competency, just do it over and over and over again. And I always say, think about, the first echo or the first ultrasound you ever did. Sure, you were incredibly nervous and now you can probably do them with your eyes closed. And so the same thing with any skill that we're learning is just doing it over and over again to try to get competent in it. All right, I'm gonna just rush through this real quick to try to finish up on time here. So the goals in contrast imaging for our echo is, you want those clear endocardial borders, you want that nice homogeneous fill of the LV, you want that apex filling well. And that starts with the injection. So again, when we're training our sonographers to inject and we're doing these competencies with them, we need to make sure they're understanding that the rate of injection matters, right? You want to flush the IV first and make sure there's no resistance. There's been so many times where I've gone up and they're like, Jess, I'm trying and I injected and I'm not seeing anything. And I take out their contrast and I look at it and it's clear now. And I try to flush the line, it's not really flushing and I'm getting a ton of resistance. So as they're pushing and getting all that resistance, they're literally just destroying the bubbles in the IV. So make sure you have a nice, easy push and you're not getting that resistance. And the size of the IV tubing makes a difference too. If you have a really long or really wide IV tubing, you're going to have to obviously inject more to get it to go through than otherwise. So for these 2 side-by-side pictures, we know that we would not inject the same rates and amount for both of these, right? Because the heart on the right looks like it's pretty good. The heart on the left has clearly this big blown out apex, very significant systolic dysfunction. And so if we injected the same amount of contrast at the same rate for both of these images, we would get something like this. The one on the right would fill fine. We'd be able to see it okay. The one on the left, you would get all that swirling. You wouldn't be filling the apex and you wouldn't, I can't tell if that's a thrombus in the apex. I have no idea. So it's really important to know the pathology, know what you're looking at, and know how you have to change your rate of administration in order to account for that. And this is just another quick side-by-side here. This is the exact same patient, the exact same day, the exact same study. This is the one on the left. It just did not fill, so we're not able to see that true apex there, and I don't know what's going on there. And then we look on the right, and once you really fill that true apex, you can see there's actually this akinetic and small dyskinetic segment up on the top there. And so this one was a really tough study, and the sonographer actually came and got me, and we really had to work to get the image. So use each other for support and to help each other out as well. And then, mechanical MI really matters for our echo imaging too. So just check that if you're getting, if those bubbles are breaking for you, if you're getting all that swirling, you can always decrease your MI and you'll get a more cohesive image. That's you do on the right-hand side here. And just final things for our cardiac sonographers out there. Breathing is really important. These side-by-side images, same image, you have one with a breath hold, one without. Use your breathing. Contrast only does so much, so you can really, really make it prettier, for lack of a better word, if you use those breath holds. For foreshortening, I am, this is the same side-by-side picture of a patient. So the one on the left here is very foreshortened. You can see how rounded this apex is here. Whereas the one on the right, they went down a rib space and were able to see that there's actually this small aneurysm in the apex here, which if they settled on the image on the left, they would have never seen or picked up this small aneurysm on the right. So, and you can see these pictures, it's the same study, same day. It's just a matter of going down and making sure you're going through that true apex to pick up the true, to see if there's any pathology there. And then one final side-by-side of one that was foreshortened. Again, on the left, the sonographer does a really great job showing that the apex is akinetic, but you can see that it's pretty rounded at the top there. And so if you look to the right here, they did a great job and they swept through that apex to really look for an apical clot, and they found one. And you can see how the apex is more pointed. It's more elongated, and you're not getting that rounded off. So if you have an akinetic apex, it's definitely important to make sure you're in the true apex and just take the time to sweep through to identify if there's an apical clot there. All right, I think I did it in time, maybe. So this is just one last plug for ICUS. It's really an incredible organization, and membership is free. You get access to these webinars. There's access to so many documents on their website to help with anything from competencies to policies, procedures, safety data, all sorts of things. So I encourage everybody to go ahead and utilize that. So thank you.
Awesome job, Jess. I'm sorry if I ate into your time there.
No, you're fine. It worked. It was perfect.
We have a few questions in the chat box. I did answer a few, but there is one that I would like to address sort of live, which is intracavitary injections. Are they also done by a sonographer? So intracavitary routes of transmission, for urinary reflux studies, the patients need to be catheterized. So we mix the contrast solution with saline and then it gets infused. So it's actually an infusion, not an injection. So obviously the nurse would catheterize the patients and then the contrast would be infused after that. There is a question here, Jess, pertaining to cardiac. So I will leave you with that one for sure. I think it's the VSD, ASD.
Oh, okay. So the question is the contrast different than a bubble study to rule out a VSD versus an ASD? I mean, you could use contrast as, it's if you're catching it when it's going in. I mean, I guess, you could, but typically we would just do a bubble study to rule out that. I will say that I've had a couple cases, one lately, where we had a pretty significant post-STEMI VSD that we were able to really bring out with contrast. It was actually hard to see it, and then we used contrast, and you actually see the flap of that VSD kind of opening and closing with the contrast. So, for a typical, bubble study for a standard ASD, I would say it's a bubble study, it's not contrast. But don't forget those kind of other ways that we can utilize our contrast. And if you really need to prove there's a VSD, it's a great way to do so. There's one here about an adverse reaction. If there is an adverse reaction to an agent, how long before it typically shows up? These are pretty quick. And so these reactions, I mean, I've seen a few of them in my career that are kind of those anaphylactoid type reactions, and they're always almost immediate. And so I had one not too long ago that, the patient literally just looked at me and he was like, "I'm hot." And it was like right after I injected. And then immediately after he said that, he had all of the classic kind of symptoms. So it really seems to be pretty immediate. I don't think people are walking out, 20 minutes later, an hour later and getting these reactions. But how, and remember, back a while ago, we did have there was, as part of the black box warning, a mandated time to, keep the patient, to observe them, and that's no longer there for
Right.
so there's no mandated time where you need to keep a patient or hold them or anything like that.
I'm going to answer this. It says, I may have missed it, so I apologize. How can a sonographer become IV certified? So Northwest Imaging Forums has an IV training program. It's a two-part program that I shared at the introduction, and you will earn CMEs for both of those parts. In terms of certification, check with your institution. So a lot of times your institution, wherever you work, say that you need to perform so many independent sticks in order to be recognized as certification. Jess, what's your experience with IV certification? Is that your policies, I would imagine, in place, as you mentioned? Yeah.
Yeah, I mean, if we're doing it in-house, we have,
Mhm.
the didactic part, again, I literally just took all of the resources that they had for nursing and assigned them to my sonographers. So they do like the video, the didactic session through, like, my path is what our thing is for, like, all our competencies. So I just searched like nursing competencies, assigned them all to my sonographers, and then I have one sonographer that's like a IV freak and it's really good. And so to have her and utilize her in the training is great and really helpful. So she does she'll sit down and actually show you the step by step and do them with you and help you. But that's after, like, the didactic and then, like, the online video and things like that. There's a question here. My understanding was that contrast is contraindication with intracardiac shunts. Is that no longer the case? It's not. That got removed in 2007. I mean, that got removed quite a long time ago. And they did studies on that. So there was one retrospective study that was done, I think 418 patients that received contrast that had a shunt, and none of them had any sort of embolization issue, no TIA, no stroke, anything like that. So that was removed from the requirement. And so as of right now, the only contraindication of use to contrast is an allergy to something in the contrast, with the contrast, or a component of the contrast, which varies by each. But
So there were two questions, one of which had to do with ultrasound settings and what setting would optimize the image. And I think that it really truly just depends on the contrast agent that you're using, in addition to the system that you are using. So as Jess had mentioned, reach out to your bubble and vendor manufacturers to figure out how to optimize your image to the best of your ability. And then there's another, also too, I believe ICUS has a webinar, definitely in the past, they've done a webinar about image optimization using contrast. So I would encourage you to visit the ICUS website, look at previous webinars, and certainly refer to the calendar of upcoming webinars. There's also a question on here about GYM. And I do believe, I know it was talked about, but whether or not it happened, I'm not 100% sure. But I thought that ICUS was going to, or if they already did, something tells me they already did, a webinar about using CEUS in GYN. So again, just refer to the ICUS website for that information.
so there is a question about state regulations for IV certification. This is really an institutional level policy that needs to be approved and implemented. I don't know, Maria, I don't know if you have anything to say about that. I know we went through, as far as administration of contrast, we didn't find any state statutes, laws, anything that prohibited sonographers from injecting contrast in any of the 50 states. And so I think that it would be potentially similar for putting in IVs, but that really is an institutional decision. I don't know of any state regulations that govern that. Contraindications using contrast on pregnant women for echoes. It hasn't really been tested or looked at, because pregnant women aren't really giving up their asking to be part of studies for unknown things. But I think for these types of situations, you have to think about benefits for the patient. And Our policy is if a patient is ordered for contrast and they're pregnant, we just talk to the attending, and it's up to the cardiology attending to make that decision. There's no contraindication for using contrast in pregnancy. There is not. However, there may be institutions that don't do it. There maybe they are that do, and so that's probably one of those things that would vary by hospital. But there is no current contraindication.
There's a question here about using contrast for thyroid nodules. I know that they use that. There's research projects being done for using contrast for thyroid nodules routinely. I am not familiar with that. I don't have experience with that, but I know that there are research studies currently being conducted for using contrast to evaluate thyroid nodules.
One question about using contrast and flushing it immediately. I can say for echo, for cardiac, I rarely flush with saline right after. I start with a very small amount. I usually start with this like a 0.5 cc's and I inject it. I see what I get and I go from there. The only time I'm really honestly immediately following with a saline flush is when I have a patient that has like a really big blown out apex and I'm having a hard time filling the apex. And no matter like how fast I'm pushing, like I'm just not filling it. Sometimes I will follow immediately with a saline flush in those instances, but I don't think it's necessary to do it if you're getting a lot of attenuation. You can just do the contrast.
There's a question here about, I only use Definity. Are there any differences with other contrast companies? I would say yes. But I feel like truly you have to find a nice balance between the system that you're using and the contrast agent you're using, and how are you using it in what application. I don't know if you want to add any of your perspective to that, Jess.
Yeah, I mean, I think they all have differences in storage, and you know, some are refrigerated, some aren't, and with agitation, how they mix. So some have a vial mix, some are hand agitated. So there are some difference with how we're preparing them, things like that. Listen, at the end of the day, when it comes to imaging quality, at least for echo, I don't see a big difference across them. It's just I think the most difference really is the preparation of the agents and the storage of the agents.
Am I aware of any upcoming breast lesion diagnosis using CEUS? So I've worked on several research studies using CEUS for assessing neoadjuvant chemotherapy as well as breast lesion characterization. So I know that there is research about that, whether or not there are upcoming applications of that, I'm just not 100% sure. And then this one I will answer. Can sonography students get the contrast IV certification before they earn their bachelor's? So in fact, at Jefferson, we are hooked up to a big medical sensor. So I teach at Thomas Jefferson University. We do IV train our students. Our medical system accepts our IV training. So when our students graduate, the only thing they need to do is complete the number of independent sticks, and they are IV certified. So our healthcare system does recognize our training program as being adequate and meeting all of the necessary steps to becoming IV trained. So I do feel like there's opportunity there to definitely bridge gaps between an educational program and their clinical affiliates where they place their students.
Question about low oxygen saturations. Can you use contrast in a patient with a low oxygen saturation? Yes. I mean, listen, we're using contrast agents in really critically ill patients every day, and if it gives you a peace of mind, there was I think a few studies done. I think one by Mike Main, one by Kevin Way, that looked at contrast administration while doing right heart caths or like invasive, looking at like invasively right heart pressures, and there was no change between right-sided pressures, like mean pulmonary artery pressure, right atrial pressure at baseline or after the administration of contrast for patients that had zero, like no pulmonary hypertension, mild, moderate, or severe pulmonary hypertension. So they literally did a right heart cath, injected contrast, showed that there was no change in a variety of patients. And so that's when I think that's when the FDA ended up pulling back the pulmonary hypertension guidelines as well. But so that has been tested. So yeah, there's no reason why you can't use it for that subset of patients.
So there's a question about DEFINITY. I'm not sure if this pertains to echo or general. I will speak on the general side of things. Oftentimes, we're finding that with newer contrast software, the recommended dose oftentimes is a little bit too much. So we've scaled back. So it's really finding a happy and nice medium and compromise between where the lesion is located in terms of depth, as well as not only the agent that you're using, but again, those system settings. So newer contrast software is very sensitive, and a lot of times you have to scale back on the recommended dose. I'm not sure what your experience is with Echo, Jess, but that's
Yeah, I don't follow the instructions.
okay. That's a nice way of saying the same thing. Direct. It's definitely more direct than
I mean, we dilute it, and then I'm doing like 0.5, and and also too, like from a reaction standpoint, right? It's always, for me anyways, I always just like to do a little bit to start, make sure like, everything's okay. I don't want to just like shove in like, 3 cc's and then, end up having a reaction. If we're just introducing a little bit, a little bit at a time. I have no idea if there's any scientific, any science behind this, but in my mind, that makes me feel better about the chance of some sort of adverse reaction. So, but yeah, no, I usually find that you don't need the 1 to 2, and it actually, if you use it, it causes attenuation anyway.
So there's a question about training the department. I'm assuming that pertains to training for CEUS. I would say definitely identify who's going to be on your contrast team, physician, sonographer, and certainly visit the ICUS website because there's formal training, and reach out to your bubble and vendor manufacturer for additional training is what I would suggest.
Question about how fast to inject contrast for a patient with a low EF. I think it really depends. It's hard to say without being in front of it and kind of seeing it in real time. And to say like an exact amount. It says you usually inject 1.5. I think that's fair. You could always follow it with some saline. And if you normally we want our focus position for a normal EF at the annular level. But if you have a blown out apex that you're trying to fill, bring your focus position up to the apex. That's going to help fill it while you're kind of pushing more a little bit faster. So hard to give you an exact dosage, but I'd say, if you're injecting 1.5, it's, for a really low EF or a blown out apex, that's a good start. Follow it with some saline and then go from there.